I'd like to invite Dr. Ronnie George to talk on relevance of analysis on Indian population, my perspective, based on Chennai glaucoma study.
So good morning and thank you for including me in this course. So basically, if you look at angle closure disease, one of the questions that ANALIS and ZAP both tried to answer was, what is the relevance of a YAG peripheral iridotomy in preventing progression from PSCS to PSC? And that's an important question because there are a huge number of people with primary angle closure disease, and currently for PSCS in India, our protocol is that you do a YAG iridotomy in some situations. So you do it in case there's a one-eyed patient or the patient has an acute attack in the other eye, or there's a difficulty with follow-up. We don't really advise it for everybody. And the rationale behind this is because there's a huge number of people with YAG PI, and you need to assess how safe it is. So if you look at our own data, and what we had done is when we had done the Chennai glaucoma study, we had done a YAG peripheral iridotomy for all patients with PACS because that's what our ethics committee wanted us to do. So when we went back to them for follow-up 6 years later, we looked at what happened to their cataract status. And if you look at this, what you will see here is that this is the progression rate among the non-YAG population. And patients who had a LPI, you can see that the progression rates were significantly higher. And this was more commonly seen in the older age groups. So doing the laser iridotomy did result in an increase in cataract progression. But what happened with this cataract is this is cataract graded on the LOCS3 grading. It is not necessarily visually significant cataract. So definitely the YAG PI did have some impact on with increased cataract risk. And when you look at an Indian population, which at today's estimate has maybe 40 million people with PACS, if you go and do a YAG PI for everybody, you will keep the cataract surgeons happy, but not necessarily everybody else. So you have two studies, actually. You have the ZAP and the ANALIS. I'm supposed to speak about the ANALIS, but I think I should speak about ZAP also. I should speak about ZAP also because both were designed in a similar fashion. So ZAP basically ultimately recruited 889 patients from South China and randomized 889 eyes to peripheral iridotomy, and 888 contralateral eyes were just kept for observation. And what they found here was no endpoint, meaning the patient did not really have an acute attack or the patient did not really have progression, was 1% of people versus 2.9% of patients without endpoint in the control group. So basically versus progression rates were very low in both groups, and it was about half in the PI treated group as compared to the control group. And when they looked at risk factors, you basically had patients who were older, had slightly higher risk of progression, who had a peripheral limbal chamber depth which was thinner, and who had a central anterior chamber depth which was shallower. So these are the three groups where you saw progression. So what they concluded was, they said incident disease occurs very rapidly, rarely, and when it did, it is relatively benign in nature. However, the prophylactic benefit of YAG LPI was statistically significant. And they came up with a number needed to treat of 44 eyes to prevent one case of progression to PAC over 6 years with no effect on visual function. So basically, they had nobody who progressed to primary angle closure glaucoma. So their definitions of progression were an IOP of more than 24, PAS, or an acute event. The ANALIS study was something that's similarly done in Singapore. So this was basically, again, they had 480 patients who were randomized to either receive a peripheral iridotomy or the other eye was followed up without an iridotomy. And they had some dropouts in between, but not all that many. So when you look at their incidence rates, and this is per 1,000 eye years, so basically 11.6% of eyes progressed over 1,000 eye years in the LPI group as compared to 21.8% of patients who progressed in the control group. And if you look at the peripheral anterior synechia rate, 3% had peripheral anterior synechia in the laser PI group and 11% in the control group. And IOP elevation was similar, 7% and 8%. Acute angle closure, in the LPI group, they had one person who still had an acute angle attack post LPI and two people in the control group. And in terms of visual fields, a little bit of progression there, but I think that is not something which is probably very relevant. So for them to, their risk factors were age, older age, and baseline IOP post dilatation. So patients who had a slightly higher baseline IOP after dilatation were more likely to have progression at 60 months. So, so basically the endpoint was seen in 6.7% versus 2.3%. So the question here becomes, and this is their information again, about double progression rates in patients who did not have a YAG-PA was about double that in patients with control group. Again, their progression rates are relatively low. So they summarized that in eyes with untreated PAS, they showed twice the risk of endpoints developing, which are mostly Synechia over 5 years compared to YAG LPI. And they said that this confirms what the ZAP trial does. And they also say that because the progression rates are low, its observation without LPI is a reasonable observation, a reasonable option for PACS. But if you look at Indian data, now Indian data, you have two studies. One study is the Velo Eye survey, which looked at untreated how many PACS progress to angle closure. And if you look at this over the 5-year data, you see that 22% of patients progressed to PACS, none developed disc of field changes. Mongolia also showed similar 20% results. So the risk of progression, even in India, was low, but not as low as what you see in this study. So this is unpublished data, but this is data which was presented at ARVO about 4-5 years back. And this is in the Chennai glaucoma study, all the patients who had LPI, what were their progression rates? So we had 727 participants, of which 720 underwent LPI. 317 were evaluated 6 years later. And out of these, 234 were PACS at baseline. So at follow-up, 29 or 12% of these eyes actually progressed to LPI, to PSC with a patent iridotomy in place. So why are these numbers a little higher? So these numbers are basically a little higher for two reasons. One is if you look at both the Vellore and the Chennai study, the definition of Synechia was even a single pinpoint PS was considered progression. While if you look at the ZAP and ANALIS, I mean, I've spoken to both the people involved there, it was half a clock hour of PAS had to be there to define progression on gonioscopy. So most of us clinically, even a single pinpoint PAS is enough for us to define progression, which is the reason we use that. So that's the reason you have a much lower rates of progression as in those studies as compared to Indian studies. And even in the Indian studies, if you take V as Velo Eye survey as the untreated and Chennai as the treated, you still see the 2:1 ratio. So untreated progresses twice as fast as treated, but progression rates are still low. So we really don't need to change our PSS protocols in India at this point in time. The evidence does seem to support what has already been known, but keep in mind that the progression rates are not as low as what has been reported by the Singapore and Chinese studies. Thank you.
Thank you, Dr. Ronnie. That was really informative. Actually, we all meet with this dilemmas when we are managing angle closure glaucomas. So I think our concept is actually reinforced by your study. So by doing PI, that is always better than waiting.